A pleasant good afternoon to everyone and welcome to this inaugural conference. I'm here to introduce our keynote, Dr. Julieta Rodriguez Guzman. She hails from Colombia. She received an MD degree from the Pontific Xaveriana University, a specialty degree in occupational health from El Bosque University, and a master's degree in science, applied degree in occupational health sciences from McGill University in Canada. Her work during the past 32 years focused on assessing occupational health and workers' compensation systems, policies, and programs, supporting the development of workers' health promotion, and studying different working and employment conditions in Colombia and other Latin American countries. She's author of multiple articles, book chapters, and edited several books on occupational medicine and workers' health in English and Spanish. In 2019, she was elected as a fellow of the Collegium Ramazzini in Capri, Italy. In 2011, she became the regional advisor in workers and consumers' health for the Americas at the Pan American Health Organization and the World Health Organization, where she leads the implementation of the Plan of Action on Workers' Health for the Americas. Please join me in giving a warm SGU and Grenada welcome to Dr. Julieta Rodriguez Guzman.
Thank you very much, Dr. Frame, and we will be certainly welcoming Dr. Guzman shortly. Just a couple of notes as well as we begin the keynote presentation, including our welcome address by Dr. Richards, Dr. Jacobs, and Dr. Oles. Feel free to share your questions, your comments with us in the chat box, and together with Dr. Guzman's presentation, at the end of that presentation, we will proceed to our first question and answer segment as well. So just note that you can feel free to share your questions, your comments, your queries, your feedback with us, and we will ensure that our speakers are able to receive and respond to your queries. Dr. Guzman, it's now over to you, as we're all very excited and looking forward to your keynote address today. Thank you.
Thank you very much. It is a big pleasure to be here with you today. And I am going to share my screen right now. Please confirm you're seeing my presentation.
We can see it. Yep, great.
Okay, perfect. Thank you so much. So it is a really big pleasure to be with you today. It's really been a very important thing to share. I mean, it's been a very special invitation from Dr. From the St. George University. I'm sorry, I'm a little bit confused. So, but first of all, I would like to make an acknowledgement both to Dr. Richards for this very important conference, as well as to Dr. Dr. Richard Oles, as president of St. George Universities, for this very special invitation. I'm very deeply grateful. And of course, I would like to acknowledge that the St. George University and the Department of Environmental and Occupational Health has been WHO Collaborating Center in Occupational and Environmental Health. And just today, the letter for redesignation dated on October 20 was issued and sent to Dr. Richards and Dr. Oles. So we're going to continue working with you for 3 more years from August 9 of 2020 until August 9 of 2023. I look very much forward. And then, of course, I want to acknowledge the work done with Dr. Richards, Dr. Ford, and Mr. Nigel Edwards that have been my co-partners in this work during the past 4 years. And in fact, it's been 8 years now that the university has been a collaborating center for us. So thank you so much for this invitation, and really very pleased to be here with you. I'm going to address this. I'm going to divide this talk in 4 steps. I'm going to give a bit of a word about workers' health. I mean, about PAHO. Usually people know who PAHO is, but really they don't know what they do, what we do. And one of the things that we have been asked for is to say who is PAHO and how do we work, so that people can understand what we do and what to expect from us. Secondly, I'm going to talk about the determinants of workers' health. And thirdly, I'm going to talk about the challenges COVID-19 pose on workers' health, and I will give you 2 examples of the huge struggles that we're dealing with. PAHO has 2 hats. It belongs to the Inter-American System of Nations, that is with the Organization of American States, and also with the World Health Organization as the regional office for the WHO. And in this sense, we have some certain differences with the rest of the regions of the WHO, because we are the 117-year-old organization, most old organization in the world on the so for health and public health services, and we joined the United Nations in 1948. So we have a lot of things we have done at this point in time. PAHO's mission is to lead strategic collaborative efforts among member states and other partners to promote equity in health, combat disease, improve quality of, and lengthen the lives of peoples of the Americas. And our vision is to be the major catalyst for ensuring that all the peoples of the Americas enjoy optimal health and contribute to well-being of their families and communities. PAHO's supreme governing body is the Pan-American Sanitary Conference that it really meets every 5 years. But we have our directive council that in the meantime it gets together, meets yearly, and in the years of the past, and this is where we get all my mandates from. Excuse me 1 minute. So our reach is very big. We have 52 member countries and territories to promote evidence-based health actions and policymaking to tackle disease and their causes, strengthen health system, and respond to emergencies and disasters, as we're doing right now. Our list of member states are there. We have associate members, we have participating states, and we have observer states that join us in every Sanitary Bureau conference. And of course, during all these years, we have had lots of achievements. These are some of them: 45 years in life expectancy gained since 1902, significant expansion of health coverage for poor and vulnerable groups, although not as much as we would love to. And this is something that we will see as we observe what COVID is doing to our region. Latin America has the lowest infant mortality of any developing region, and Latin America has the highest rates of antiretroviral treatments for people with HIV in any developing region. So we have a lot of things we can share, but also we have huge challenges. The first one is the social determinants of health. You remember our definition: people are born, grow, work, and play, and has a determining impact on their health. And of course, it varies geographically and according to the cultures and social and cultural barriers to good health, including stigma and discrimination. The second big challenge is universal health. We promote health as a human right and work with countries to ensure that all people have access and care they need when they need it without discrimination or fear of financial hardship. Thank you. And then the other 2 big ones are the public health preparedness for responding for disaster and outbreak preparedness. And of course, this is based on WHO regional, we're the WHO regional contact point for the international health regulations. And this is what we're doing right now. And finally, the non-communicable diseases, trying to promote evidence-based and equitable prevention and treatment of these diseases, because they're the first cause of death in a region, as in most of the regions of the world. So we have big challenges. And how do we do it? We have technical cooperation in 6 big areas: communicable diseases and environmental determinants, non-communicable diseases and mental health, health through the life course, health systems and services, health emergency and preparedness, and health information and evidence, which is our transversal arm for all the things we do to really tackle and have evidence. Now, workers' health is in health through the life course. and is based in the unit of health promotion and social determinants of health, given the fact that work and employment are social determinants of health. And of course, the epidemic and alert and response is pretty active, as you well know, through the COVID-19 pandemic that we're facing right now. Now, we have to start saying that the persistence of social inequities, despite the enormous progress of material well-being, is still amongst us. And despite it is strongly associated with inequalities through the life course. This was said by Mack in 1996. And of course, it depicts the dances of the dead, a macabre mirrors of an equal society that was painted by it named this, ¿cómo se dice en inglés? It's a grabado, I cannot remember the word in Spanish, in English, I'm sorry, but it depicts how strong it was in 1538. And when we look at this and we look at our agricultural workers, there's not so many differences if you can understand. Now, one of the things we have to say, and this is growing up what PAHO do, but now we have to focus on occupational health and how do we address it from the public health approach? I think this is one of the most important messages I would like to deliver. Yes, occupational health was defined in 1950 in a joint effort with ILO, and it has been the basis of all the work that has been done during the last 70 years. However, since 1984, we recognize that there is a difference between the labor approach and the public health approach. And from the labor approach, where we talk about occupational health and safety, or occupational health at work, safety and health at work, we find really crucial differences. I'm going to mention just a couple of them because it's employee workforce. That means formal workforce. They are tied up by a labor contract. It is the employer's responsibility to provide the occupational health services. It focuses on the workplace and only related to health issues, if needed, will be coming to the health sector. Bargaining between workers and employers is usually done, and it is a privilege of few versus the decent work that we want to promote together with the ILO. While the public health approach, we talk about workers' health, and we deal with all workers. Every person that works has the right to health beyond the workplace. It's a responsibility of everybody. It considers health, all health determinants. It uses the health and health policy approach, and it combines and acts with other stakeholders, insurance, health, environmental authorities, etc. And of course, it provides health protection because, again, health is a human right. And it's a different approach. And from that point of view, it doesn't matter what type of person, what type of population, what country you come from, if you work, you have the right to health. That's it, that's all. Now, we also have to think about the way that occupational health and safety and workers have evolved from the very old traditional approach back in the 60s and 70s that was based on the work-health relationship. It evolves to the 80s and the 90s with a holistic approach to talk about quality of life at work. And finally, between 2004 and 2008, with the Commission of Social Determinants of Health, we have a clear difference between employment and working conditions that definitely mark the life of workers. And finally, nowadays, we use the social and environmental determinants of health at work with a multi-causal approach, multi-systemic and multi-sectorial approach. And it's based on the Sustainable Development Goals and also in the global health promotion that created the framework for health and health policies. And of course, this is part of the things that we have been doing, considering particularly, as you can see in the right down corner of the screen, employment and working conditions are specifically considered very important determinants of health. And of course, I'm not going to review the definition of this because this is so well known to us, but we have to enhance that this is basically one point in time that really challenged and changed the focus of public health. And of course, it provided overarching recommendations for workers, particularly with the employment network that was built for this purpose. And in the overarching recommendation and principles for action were to improve conditions of daily life, tackle inequitable distribution of power, money, and resources, and measure problem, evaluate action, expand knowledge, and develop a workforce that is trained in social determinants of health. And in this sense, the MCONET, they say we need fair employment and decent work. And in action 3 of the recommendations, they say improve working conditions for all workers to reduce exposures to hazardous conditions, stress at work, and unhealthy behaviors. So today, how do we perceive what determines workers' health? Of course, the working environment, the traditional approach, working conditions, physical, chemical, biological, safety hazards, ergonomic stressors, and so forth. The social factors that we frame as the employment conditions, how much salary you have, do you have a contract, do you have privilege, are you under social protection, do you have a workers' compensation, etc. The status, the economic status, we have a lot of people in poverty and extreme poverty in our region, so this we have to take into account. Equity, gender equity, ethnic equity, age, residence, etc. The relations between employer and employee when the formal relation exists is very important, but also we have to remember that the worker has a family, a community, and a union, and all these social relationships of the worker influence their health, his health too. The other two packages are individual work related to health practices. This is behavioral conditions, individual behaviors, sedentary work, diet and nutrition, unhealthy habits, smoking, alcohol, religious and cultural practices. This is very important precisely because workers are the age group that finally get non-communicable diseases. So these influence very much their performance at work as well. And finally, access to health services, comprehensive health services that can allow to offer preventive occupational health services, healthcare, that means care and rehabilitation in case a worker gets diseased or injured, health insurance and workers' compensation schemes, or occupational disease and accident insurance. Some countries call it like that still. So from that point of view, this is what determines, but independent of that, the individual has the right to all these other determinants: economic stability, neighborhood and environment, education, proper access to foods, community and social context, and health system care with health coverage, provider availability, provider linguistic and cultural competencies, and quality of care, because all of these definitely mark health outcomes, being mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations for the worker. So it is a big combination of all these things, and we need to really define what does the Commission recommends as actions. Of course, they're based in social justice, methodological changes, political will, involving countries, civil society, knowledge networks, global initiatives, and of course, our region, to make full and fair employment and decent work a central goal. To achieve healthy equity requires safe, secure, and fair paid work. To improve the working conditions for all workers, and to establish and strengthen universal comprehensive social protection. And this last one is very important nowadays, facing the COVID. Now, 2 words for enhancing the importance of the public health approach and its basic functions of health assessment and monitoring of communities, formulating public policies designed to solve health problems, and ensuring that all population have access to appropriate and cost-effective care. This is probably one of the biggest challenges we have right now, because what we have seen through COVID is that many of these things are weak. And remembering health and all policies, a collaborative approach for improving the health of people by mainstream health lens in decision-making in all sectors and policy areas. This is very important. It allows to develop capacities to recognize and support the development objectives of all the sectors, recognizing the interdependent nature of social, economic, and environmental development of health. I mean, health is the core that makes us manage there. So workers' health is one of those situations in which a health and all policy approach must be considered because it's a complex health challenge. It implies external policies with high impact on health, and at the same time, it implies that it must be a government priority because it affects many sectors. And in that sense, effective collaboration is required and must be applied in all its levels. That means from informal collaboration all the way to formal collaboration. That means when the collaboration has an actively ensured goal and achievements with shared responsibilities, with shared policies and practices, with autonomy for further automated still, and working together for common goals. All the others in the back that are communication, cooperation, coordination are very important too, but collaboration is the key for making health and all policies happen for workers' health. Now, just a quick reminder of how many workers we have in the Americas. We are, according to our statistics, basic health indicators, we are already 1,014,617 million in the Americas, out of which has increased a lot if you compare with 2005 and 2012. And of course, it is distributed more or less in, the labor force is distributed in the Americas, 39.5% in North America and 60.2% in Latin America and in the Caribbean. So we have a huge mass of workers. And of course, labor distribution in the Americas will depend on employment conditions and in working conditions. Of course, employment conditions, as I said before, are determined by contract salaries and social protection, while working conditions are derived from the nature and the processes of work, and of course, the presence of hazardous conditions or risks. And of course, this division itself creates some type of inequity, and also it's determined by the regional heterogeneity. We are the most heterogeneous region of the developing world in Latin America and the Caribbean. Now, just a quick review, workers' health is seriously sick. We have a lot of problems with employment conditions because we have a lot of precarious employment, subemployment, forced labor, labor exploitation, child labor, violence at work, just to mention some of them. The informal sector or the informal employment is closely, the last data from ILO spoke about 54% of the economically active population, and it's increasing right now because of all the things that have been happening with COVID. And of course, hazardous exposures persist and increase now even more. Occupational injuries, we estimated that for the Americas, we had 7.6 million injuries per year. That meant 20,850 per day. And because of very weak information systems, updating this is very difficult. Occupational diseases, we estimate 140 million per year, only 5% report in Latin America. And we come back to the invisible epidemics that ILO declared back in 2013. And we're still in there struggling to make people diagnose and have compensation for their disease. NCDs are the main cause of death in productive age. Communicable diseases are emergent and re-emergent diseases, and now, of course, the principal, which is COVID-19. Problems with women in work, with gender segregation, invisible ceilings, harassment, etc. And of course, vulnerating, or how do you say, in Spanish we'd say vulnerando, workers' rights. The workers have the right to decent and healthy work, to well-being, to health, to life, to development as a person, to be happy, etc. So we really need to observe these things. Just a quick review of occupational diseases to let you know that there is still a lot running around the region, and that we have to look at those occupational infections. So of course, right now we're focused on COVID-19, but occupational cancer, allergy, problems of mental health at work now rising very strongly, because of COVID. Musculoskeletal disorders and physical hazards like hearing loss are still a big chunk of the agenda. And it's been like this for the last 30 years since I've been practicing occupational health. So it's really something that we have to look at very carefully. Now, just to mention some of the inequities that need to be made visible. Child labor, for example, we're talking about 152 million children working around the world, and 73 million in hazardous work and mining and agriculture, et cetera, et cetera. In the age profile, imagine children from 5 to 11 years of age are the 48%, economically active in agriculture, in industry, and in services. So this is something we looked at. Now, forced labor. This is data of the most recent gather I could put together from ILO. 40 million, 12 years, in 2012, we estimated that it was 20 million globally. And now it has increased very significantly. The prevalence is 5.4 per 1,000 workers. And of course, guess who are the most gender-wise? Women and girls are 71% of this labor. But debt bondage is 50% and children are 25%. So we need to, these are the inequities that we would like to break down. So if we look at the social determinant of self approach to core regional challenges, we need to really tackle and try to make the balance to see how we can move the agenda from 2015 to really attain the 2030 SDGs. Now, I have to make a word about what ILO has built as a statistical profile for informal economy. And informal employment and formal employment are really challenging for the world and for the developing world and the emerging world. And if you can see the world, if you look the world as a whole, we sort of see a 60% of informal work and 40% of informal employment. But if we look at the developing world, it's 90% in average versus formal work for formal employment. So this is something that that has struck very strongly, precisely because of some of the things that we will look at a little bit later. Share informal employment and total employment. Look at the share of less than 20% is only in the United States and Europe and Australia. The rest, we are in the midst of 20 to 89%. In some countries in the region have 90% of informal work. The gender dimension, of course, if you look at the world, it seems more men than women, but if you look in the developing world, 92% of the women are in informal work. So this is something that we have also to look at. The level of education of workers is not a guarantee to, but an important asset to access formal employment. So we need to educate people. And if you see how education is in our region of the Americas, in the left corner, in the left side of the graph, you will see that we have been improving from no education to tertiary education. However, we still have lots of, in the developing world, we still have a lot of informal work, as you can see right here. As well, poverty is a cause and a consequence of informality. And this is the poor face higher rates of informal employment, and the consequence is higher poverty rates in the region and of course around the world, but of course in our region is also very bad. So inequalities and barriers of health system is a second element we have to analyze. The critical role of human resources for health is very important. And you know that right now we have a huge gap of probably estimated to be between 20 and 30 million health workers that are missing to really address all the problems. And plus they're being very much affected by the COVID. So it's in a scenario that we need to to tackle, but also we have to address the 29% of the population before the poverty line, and 40% of the poorest population receive less than 50% of the total income. So provision of health services become a barrier for those that do not have the money or are not protected through social social protection programs so that they can address their health. Added to this, and I'm not going to stand on that, we need to reach universal health coverage. We need to tackle climate change. We need to address emergent diseases. We need to talk about aging and health because there are countries with a big amount of aging population. We need to talk about national and international migration. We need to how to involve civil society and community in the health policy making, which is what basically health and health policy asks us to do. And of course, we have to familiarize public health and information society so that we can really address all the things that this huge challenge gives us, the 2020 global challenge. As you can see, we have big problems. We have, the world is altogether in big problems. But in our region, the cases per million reported have been increasing in Argentina, Colombia, in the United States, and some of the countries of Central America, as well as in Europe. If you look at the left top corner, you will see how the Americas in yellow have been increasing. The line you see there is the number of deaths, and it's increasing as well. And the new things that I've been seeing lately, and this is innovative, this was from the report made as of October 18, is that elderly are not so much exposed as the people between 15 and 24 years of age, and between 15 and 24. So what we're seeing is that the pattern is changing, and we have to look at those things as well. And the worrisome part for us is that between 15 and 64 years of age, people, what do? They work or they study, or they don't work or not study, but most of them are there for us. Now, for the region of the Americas, more specifically, the panorama is again very, very worrisome. This is data, cumulative data until 1st of November. And the countries that are with the highest number of cumulative cases are USA, Brazil, Argentina, Colombia, and Mexico. And the highest number of cumulative deaths, USA, Brazil, Mexico, Peru, and Argentina. The numbers as a whole are 20.7 million of cases, 642,000 deaths, and 52 countries and territories counted for epidemiological purposes. And of course, PAHO has a whole set of response pillars that has been working, which I'm not going to stop right now and tell you all of that because it will take another hour. But what we want to make emphasis is in what we are doing as in the plan of action of workers' health, trying to prevent and to enhance preventive interventions at the workplace with collaborative and coordinated actions with all economic sectors to protect and safeguard life and health of workers. And for this, the ministers of health committed when they approved this action plan back in 2015 to set in place policies and intersectoral strategies, comprehensive and competitive health services, and strengthen primary healthcare services so that people with no social protection under the poverty lines can be addressed as well. The goal, of course, of the action plan is to strengthen the response of the health sector to provide comprehensive health services for workers during the life cycle and decrease health through implementation of updated policies, decrease damages to health through implementing updated policies, plans, and regulations and inequalities. And for this, the ministries will strengthen technical and institutional capacities actions to prevent and control conditions that cause injuries, diseases, and death, and promote and protect life. This requires the leadership of health with applying the fundamentals of health and health policies, closing the gaps of inequalities, and improving universal access and coverage for health for all workers. It has 5 strategic lines of action, and I just want to mention that action line 2, identify, evaluate, prevent, and control hazardous conditions and exposures at the workplace, selected 4 critical sectors. Of course, one of those sectors is health, and the second one was the informal, agriculture and mining too, but I'm going to show you some examples of what we're doing. And strategic line of action in 3 also increases access to health coverage of health services. We need to strengthen capacities from the bottom up, from basic primary healthcare teams with community participation and determining inequalities with our teaming with our colleagues of social determinants of health. So the basic recommendations we give is to build a national outlook of workers' health that allows us to see what is happening. It's a picture of what is happening in workers' health in the country. And based on that, you can issue some regulations, some kind of determination, and this will be easy for us to then formulate a national action plan on workers' health. Based on that national profile, showing and addressing national realities, defining priorities for action that will determine objectives and goals, and intervention to apply mechanism, resources, and supervision from all the parties involved. Of course, we enhance schemes to prevent and register occupational diseases, injuries, and deaths, and occupational non-communicable diseases. As I told you, we have a huge problem in the region, throughout all the region. There is no exceptions, even in North America, to address with adequate information the situation of workers' health. And of course, the national worker health programs for specific critical sectors, which I just mentioned before, health, informal, agricultural, and mining. And how do we implement this? Of course, with the government leadership, with participation of employers and workers, and of course, with PAHO support for implementation. We use partnership with ILO, Organization of Employers, trade unions, civil society, and the private sector, standard setting, giving guidance, contribution to adoption and implementation of international labor conventions in the case of ILO, articulating policy options for national agendas, monitoring, addressing health trends, and of course, providing scientific and advisory mechanisms. And of course, we do the review and monitoring at national and international indicators of achievement and reporting to PAHO. And we just reported to PAHO in our last governing classes. How do we do it? How do we do all this work? Well, we have a wonderful network of collaborating centers in which St. George University is part of. As I said at the beginning, we've been working with them for now 8 years. So let me tell you about the health sector. How do we care enough for those who care? So in the 2014-2016 Ebola outbreak, the risk of infection for healthcare workers was between 21 to 32 greater than the general adult population in West Africa. Latent tuberculosis, 54% of healthcare workers in low and middle income countries have 25 times more risk than general population. COVID infections, highest risk of COVID infections, of course, in the healthcare workers. Chronic low back pain, between 44 and 83% of nurses in Africa suffer with low back pain. Occupational burnout, between 17 and 32% of healthcare workers in developing countries have burnout. Violence at the workplace, 63% of health workers report experiencing any form globally. Suicide, medical profession in high risk in all parts of the world. Depression, anxiety during COVID, 23% of frontline workers worldwide, and insomnia, 39% of frontline healthcare workers worldwide. So you see, we're not talking about simple things. The health workers need our help, and this is why we are really joining forces within the house with different areas, infection control, health systems, patient safety, social determinants of health, etc., to really understand the situation. This is very recent information about what we are assessing, covering among the health workers in the Americas, 620 cases. And you can see all the countries. There is something, of course, some weak denominators may seem to have very big cases, like in Santa Lucia, when you see the graphic in the orange. But definitely we need to put the information together, and it has been very difficult to put it together. 2,585 deaths, which is very important also. And of course, the age distribution, and as you can see, the orange lines are females and the blue lines are males. Of course, this is explained also because the workforce and service is basically composed by women. We also did a survey of regulatory frameworks for occupational health safety for the health sector in times of COVID-19, trying to see how much coverage from the law was available for these workers. And we tried to find out which countries or how many countries with national occupational health safety policy for the health sector were really active. And as you can see in the first pie to the left, only 41% had something. Countries with national occupational health and safety action plans for the health sector, that was even lower, only 29%. And if you look at the Social Security coverage, thinking about pension plans, workers' compensation, and health insurances that will provide assistance, money, and preventive schemes, you can see it's also very weak. And Social Security coverage for contingent workers, that was also very impressive. This was done together with the Latin American Association of Occupational Health, and 18 countries responded. So this does not include the Caribbean countries, just to make sure, because this was done in Spanish. So Social Security coverage for migrant workers also, it was sort of yes, it was sort of no, but as you can see, it still is a very complicated issue. Now, countries with list of occupational diseases, 82% said yes. Countries declaring COVID as an occupational disease, 82% said yes, but only 3 were really the ones to state COVID by a decree or by an official regulation as an occupational disease. Now, other things that have been affecting workers' health, and we try to explore if there were regulations about psychosocial aspects like social protections for mental health, prevention for mental health, for assistance for emotional and stress problems, regulation on psychological harassment, and shift working. And the highest was, of course, psychological harassment at work, but mental health problems with social protection. But again, we feel that there is really very weak regulations towards these aspects of workers' health that are really affecting them badly. So what good things have happened? There is a charter of health worker safety, a priority for patient safety, and this was issued back on the 17th of September. And the idea is that health worker safety is as important more than ever. You will see in us in the House, both in a global and regional level, and even within the country level, occupational health and safety or workers' health has very significantly improved our status and importance, because we need to establish synergies between health worker safety and patient safety policies and strategies, and develop and implement national programs of occupational health safety for health workers. Now it's a must. And of course, protect health workers from violence at the workplace and improve the mental health and protect from physical and biological hazards. So now the mandate is to develop and implement national programs for occupational health safety for health workers. There was a guideline issued, a policy brief, and a checklist to help countries develop this. And of course, it is tied up with an indicator in the monitoring and evaluation framework of WHO, where we want to see that everybody develops and implements national programs of occupational safety for workers in the line with occupational health policies. So this is basically what we're doing, and we're looking forward to this. The second example I want to show you very quickly, I think my time is running out, is identifying solutions for populations in situations of vulnerability related to COVID public health measures. As I explained before, our socioeconomic context makes us the most inequitable region of the world, huge inequalities and inequities. 80% of the population lives in cities. Informal economy has grown over 54%, and there's a lot of exclusion and violence. Our products, our economies are really, really being jeopardized. The region has little room for increase of fiscal spending and owing high debt, risking rising interest payment tax and tax revenues. The pandemic will lead to the most severe contraction of the economic activity in the region's history, and a broad variety of policy responses for economic and social effects of the pandemic need to be taken. We did, the team of social determinants of health did a review of how the measures of public health have impacted these populations in vulnerable conditions. And of course, the first structural explanation is that pre-existing social economy and political inequalities increase inequity in all levels, social, economic, and political. There's a lot of high barriers to implement measures and low adherence, and this has increased the risk of exposure due to difficulty in complying with the recommended public health measures. For example, if you live in a house and share your one bedroom with 10 people in the house, you cannot do social distances. If you don't have water and soap, you cannot do hand washing. And in many of the countries have seen this. Many effects and impacts of measures such as social distancing in population, additional burden of mortality and mortality beyond COVID due to the adverse effect and on health by health measures, and increased risk of mortality, comorbidities, NCDs, and others because of the complications of NCD. So the analysis based on the measure taken by countries detected the problems, barriers to implementation, unintended consequences, and aspect-provoking rejection. They studied which populations and which solutions needed to be put in place to eliminate barriers and to mitigate unintended effects, and what actions needed to be tackled in critical sectors, intersectoral mechanisms, levels of government, community participation, and international organizations. And this led to understand that previous inequality is highly visible, and this is the biggest problem, inequalities. Economic sectors are involved or interested, including the primary sector, and this needs to be determined with policies, and improve health as a social determinant of health and equity approaches require arguing that healthcare is not sufficient to address the pandemic. And this is the new normal. It should be mean a better normal for all. So challenges are big, basically. Attaining the sustainable development goals related to no poverty, good health and well-being, and decent work. And of course, the pandemic caused health, social, and economic crisis in Latin America. If you read today The Lancet, there's a very important article and very sad one that speaks about the social economical crisis of Latin America thanks to the pandemic. Health system and emergency preparedness need more support and strengthening. Living conditions, limited options to self-isolate, family burdens, and multiple jobs threaten health of workers, health and well-being, and need to be considered. Protecting vulnerable populations require addressing pre-existing social political inequities, eliminating barriers to comply with public health recommendations and control additional adverse effects. And they should involve intersectoral mechanisms, and this is where health and health policy has a big duty to do, so that we can have a participation of society as a whole and government as a whole to really try to address these problems. It's one thing thinks the policymaker in the big building, and another thing thinks these people that have nothing to eat during a couple of days, or that have to be living all down in a little room. And as per citing Dr. Etienne's arguments, our Director, Health and Economy, a necessary convergence to face COVID-19 and return to the paths towards sustainable development in Latin America and the Caribbean are needed. So I guess with this, I finished my presentation. Thank you very much. I hope I didn't rush too much, but I thought I had the 40 minutes only for me, not for questions and answers, but if there's any, I will be more than pleased to try to answer whatever you